Your patient's blood pressure is low, but are they shocked? Are they at risk from having end organ damage or even dying? This tutorial will look at the patient who is hypotensive and shocked, and I'll show you how to work the problem, how to figure out what's going on with the patient to make a diagnosis. An introduction to critical care, presented by me, your host, Pat Nelligan. The blood pressure. Part 2. Hypotension and shock and how to work the problem. In the previous tutorial, we discussed the components of blood pressure, heart rate, stroke volume, and peripheral resistance. I discussed the circulation that consists of fast and slow compartments, how venous blood is kept in a low pressure reservoir, that stroke volume is determined by venous return and cardiac compliance, and arterial lines are the standard of care for blood pressure monitoring. Nevertheless, most of the time in our clinical practice we use oscillometers. They're great, but they have limitations, and they principally measure mean arterial pressure. In this tutorial, I'm going to talk about hypotension, what it is and what it is not. Sometimes it is an outward manifestation of a shocked state, and after defining both of these, I'm going to discuss clinical scenarios of hypotension and shock and how to work the problem. Hypotension is a fall in the blood pressure from what is normal for that patient during their circadian cycle. Blood pressure is lower during sleep and during anesthesia, and frequently we are called to patients who are sleeping deeply at night and their blood pressure is fallen. This may well be normal for that patient. There's no set diagnostic criteria for hypotension, but a fall of mean arterial pressure by 20% is one way of labeling it. Hypotension may or may not result in tissue damage. Shock represents inadequate delivery of nutrients to the tissues that may result in a life-threatening condition. The tissues don't get sufficient, in particular oxygen and glucose, to maintain function. As a consequence, there is cellular damage if this is prolonged or not reversed. There is impaired organ function, and the patient may or may not be hypotensive to be shocked. So hypotension is not shock, and shock is not hypotension, but they're often linked. Now, blood flow is cardiac output, and as I've mentioned before, cardiac output is heart rate times stroke volume. Blood pressure is cardiac output times peripheral resistance, and that therefore means that blood pressure is heart rate times stroke volume times peripheral resistance. These are all the components. If one of them changes, the others adjust. Which of these two patients is shocked? Patient 1 with a heart rate of 120 and a blood pressure of 110/50. The urinary output is 5 mL per hour, the mixed venous oxygen saturation is 40, and the lactate is 10 millimoles per litre. Patient 2 has a heart rate also of 120. The blood pressure is 76/40. The urinary output is 30 mL per hour, the mixed venous oxygen saturation is 70%, and the lactate is 1.5. Well, patient 2 is clearly hypotensive by most people's definitions, but the patient is showing evidence of end organ perfusion. They're making urine. They're extracting a moderate amount of oxygen from their blood, and there is no evidence of anoxic injury or, for example, excessive stress. But patient 1, who looks like they have a normal blood pressure, has poor perfusion to their kidneys, is extracting a lot of oxygen from hemoglobin, and the lactate is very high. So patient 1 is shocked, patient 2 is not. So hypotension is not shock. Blood pressure reflects both resistance and flow, and if resistance is very high, as in the case of patient 1, you get a normal looking blood pressure but very little flow. Hypotension is an indication of an abnormality of heart rate, stroke volume, and peripheral resistance, and failure of the others to compensate. A patient drops their blood pressure in the ICU or in the operating room. This happens all the time. It happens most commonly after we've intubated the patient in the ICU or in the operating room, and it's absolutely imperative to know that you have genuine hypotension and this is not a measurement error. So you need good husbandry. the first thing to do is always cycle the blood pressure cuff that you will be using after induction, pre-induction. For example, if a patient comes to the operating room, you might think, oh, it's okay, we've checked the blood pressure on the ward, we know what the patient's blood pressure is. Well, there's lots of reasons to disbelieve that. But once you put your own cuff on, you need to know that your cuff is accurate. So cycle the cuff before you push drugs. If the cuff is too loose, the blood pressure will be mismeasured as low. If you have an arterial line in, check the location of the arterial line transducer. It should be at the level of the right atrium. If too high, the blood pressure reads low. If too low, the blood pressure reads high, and make sure that the arterial line is correctly zeroed. The first question you have in the ICU or the operating room with an abrupt drop in the blood pressure is this iatrogenic hypotension? So let's look at that. When we have hypotension, we have three components: a problem with the heart rate, a problem with the stroke volume, and a problem with the peripheral resistance, and failure of the others to compensate. A problem of the heart rate may be caused, for example, by vagotonia, where vagal responses are increased, and this can happen with opioid analgesics, for example, fentanyl or remifentanil. Sometimes it's a vasovagal reaction. We've just performed a paracentesis or placed a chest drain, or a young man gets sight of an IV cannula that you're about to put into him and he becomes queasy. It may be caused by beta blockers that slow the heart down. Problems with the stroke volume may be caused by increased venous capacitance. A patient has just had a large dose of furosemide. That leads to a reduction in preload. The patient may, of course, be hypotensive because they're bleeding and they have hypovolemic shock, and you may have given the patient a vasodilator, thus manifesting hypovolemic shock by increasing the unstressed blood volume. Nitrates like glycerol trinitrate will cause venodilatation, increasing the unstressed blood volume, and that will reduce venous return. Positive pressure ventilation, in particular high levels of PEEP, reduce venous return. And of course, if the patient is in the operating room and they're having laparoscopic surgery, the increase in intra-abdominal pressure caused by CO2 pneumoperitoneum may well reduce venous return. The third cause of iatrogenic hypotension is a problem with peripheral resistance, and this is usually caused by the administration of drugs that directly vasodilate the patient. The most common of which is propofol, that is given for anesthesia and sedation in the ICU and induction in patients who you're placing an endotracheal tube, and it's a significant vasodilator and it nearly always causes a mild to moderate drop in the blood pressure. Volatile anesthetic agents also cause hypotension by peripherally vasodilating the patient. The other drugs that we give are calcium channel blockers like nicardipine, sodium nitroprusside, hydralazine, and alpha-1 blockers such as phenoxybenzamine or phentolamine or prazosin. And drugs that people often forget that are major vasodilators are alpha-2 adrenoceptor agonists. They are dexmedetomidine and clonidine. And these drugs not only cause vasodilatation, but they also drop the heart rate. So you will see a modest drop in the blood pressure with these drugs. You also sometimes see a drop in the blood pressure after a tourniquet has been released because of the release of vasodilator metabolites. This is often a transient response. The blood pressure falls and the oxyhemoglobin saturation drops transiently, but usually recovers quite quickly. And of course, if a patient's had a spinal anesthetic or has an epidural in place, that has an impact on the heart rate, the stroke volume, and on the peripheral resistance due to a generalized antiadrenergic response, reducing sympathetic tone, causing vasodilatation of the legs, and often also dropping the heart rate. Once you've outruled iatrogenic hypotension, you need to think about clinical causes of hypotension, and that's the real focus of this tutorial. And again, there's a problem with the heart rate, a problem with the stroke volume, or a problem with peripheral resistance. With the heart rate, we may have bradyarrhythmias, tachyarrhythmias, or an inappropriate bradycardia in a vasodilated state. With the stroke volume, this may be volume related due to hypovolemia that may be absolute, for example, the patient is bleeding or vomiting, or relative, where they have redistributed blood volume or plasma volume to another part of the body, such as in what we see in sepsis. The patient may be hypervolemic, and as a result there's very little motion going through the venous side of the circulation. There may be inflow obstruction into the right or the left side of the heart caused by pulmonary embolism, cardiac tamponade, pericardial effusion, or high levels of PEEP. It may also be a pressure-related problem where there is loss of contractility of the heart. For example, cardiac ischemia will result in diastolic dysfunction and loss of compliance of the heart and loss of contractility of the heart. There may be a myocardial contusion sustained in a motor vehicle crash, or there may be outflow obstruction, mitral or aortic stenosis, or the placement of a cross clamp across the aorta. And finally, a problem with peripheral resistance is loss of normal sympathetic tone. It happens with neurogenic shock, but it's also seen in vasodilatory states, the most common of which, of course, is septic shock. We sometimes see this with anaphylaxis, and we sometimes see this with local anesthetic systemic toxicity or other poisonings, for example, with calcium channel blockers. So shock is inadequate fluid in the system, that's venous return and stroke volume, and we call that hypovolemic shock. There is inadequate flow, and as a consequence, the tissues starve. It may be due to failure of the pump, and we call that cardiogenic shock, and there are multiple causes of cardiogenic shock. Or it may be failure of the vascular system, neurogenic shock, anaphylactic shock, or septic shock. So now we have the hypotensive or shocked patient. Let's look at how to work the problem. This is an approach that I have been using for many years. I believe I developed this approach myself. It was in the original CCM tutorials website. And I think it's a good stepwise way of approaching hypotension that you should run through very quickly in your head. And it works like this. The first question is this genuine hypotension? Second, is the heart rate appropriate for the blood pressure? 3, is the patient hypovolemic? 4, is the patient vasoplegic? That's pathologically vasodilated. And 5, does the heart contract normally? I'm going to illustrate this with a scenario. Lily is 78 years old and she's scheduled for lower limb surgery. Her observations on the day ward include a heart rate of 66 beats per minute and a non-invasive blood pressure of 80/50. The blood pressure cuff is fitted correctly. The intern wants to cancel surgery and investigate with a cardiology consult, an echo, etc. So we have a hypotensive patient, and the first question is, well, is this genuine hypotension? Lily is an excellent historian, and she says her blood pressure is always low. She is awake and completely asymptomatic. So this is not hypotension. This is her normal blood pressure. Everybody's blood pressure is different, and there will be people who normally have a high blood pressure and people who normally have a low blood pressure, and they've had that all their lives. So this is not hypotension. And again, I will point out, you always have to be careful that this is not a measurement error. Now let's look at a clinical scenario of a patient who actually is hypotensive. An 84-year-old woman is admitted with an episode of loss of consciousness. Her blood pressure is 76/44 on cuff measurement. The cuff is fitted correctly. Her heart rate is 40. No collateral history is available. So what we have here is a hypotensive patient. It seems to be a genuine hypotension. So the first question I always ask is the heart rate appropriate for the blood pressure? And the answer here is no. Her heart rate is 40. And this is a typical ECG of a patient in this situation. And if you look carefully, you will see that there are normal-looking QRS complexes and narrow QRS complexes, but there is no relationship between the P waves and the QRS complexes. So this is complete heart block with a high escape rhythm. And this patient needed a pacemaker. Initially, a transvenous pacemaker was placed, and subsequently she received a permanent pacemaker. Now, you don't have to be hypotensive to be in complete heart block. This was a patient that I had recently in the operating room, gave me permission to use this picture, who became profoundly bradycardic in the OR. You can see a very scary looking heart rate, but the blood pressure was reassuring. And this heart rate was resistant to atropine. Now, the patient woke up fine at the end and had a permanent pacemaker before he left the hospital. A 74-year-old female undergoes a laparotomy for bowel obstruction. Background history of type 2 diabetes, coronary heart disease. She's a pacemaker. On her first night post-op, her blood pressure is 80/40 and her heart rate is 60. Dobutamine is started. The blood pressure came up, but the next day we can't get the patient off dobutamine because her blood pressure falls every time we try and wean it. The key thing to understand here is that this patient has a fixed heart rate, and her heart rate is fixed at 60. She has vasodilated from her operation. She's probably a little bit hypovolemic as well. And normally when you vasodilate for surgery, your heart compensates by increasing the heart rate. So you would think that if her blood pressure had fallen, her heart rate would be 90 to 100 beats per minute. Now, sometimes that settles with some volume replacement. But she couldn't do that because the pacemaker is set at 60. So the easy solution for this is just to get cardiology up, to reset the pacemaker to 90 beats per minute, wean off the dobutamine, and once the patient's stress response has resolved prior to discharge from hospital, put the pacemaker back to a rate that suits that patient. A 24-year-old motorcyclist is hit by a truck and he's brought into the emergency room. There are multiple long bone fractures. His pelvis is fractured, he has lung contusions, his heart rate is 120 and his blood pressure is 100/60. The hemoglobin is 12.6. Is this patient shocked? Well, working through the problem, we know that it's likely that this patient has a problem with his circulation. And although he is not typically hypotensive, there is a strong suspicion that this patient is severely hypovolemic. And it's really important to understand that when we lose volume, we auto-resuscitate ourselves by mobilizing blood from our extremities, particularly the legs, and then from the splanchnic circulation. That's the blood that is located around the liver, the kidneys, the bowel, the spleen, etc. And a lot of the circulating volume is located between the legs and the splanchnic circulation, and this can be mobilized by stressing it up by venoconstriction and delivering it into the systemic circulation. That is the flow of blood that goes from the brain to the heart and back again. And so even though the blood pressure may appear relatively normal, this patient may be in a state of compensated shock. And hypovolemic shock can be absolute due to a devastating loss of blood volume, or relative due to redistribution, for example with capillary leak, that fluid extravasates into the interstitium, or vasoplegia, where there is dilatation of the arterioles and venules and the unstressed blood volume increases in size. The key thing to understand though is if there is absolute hypovolemia and there is intense venoconstriction and redistribution of blood from the extremities and from the splanchnic circulation into the systemic circulation, then the hemoglobin may remain normal. And this is what happens in hypovolemic shock. Blood is lost and there is intensive vaso and venoconstriction. So the actual volume of the circulation falls massively. There is a fall in the end diastolic volume, an increase in the ejection fraction, and an increase in the heart rate. There is venoconstriction with mobilization of splanchnic blood, arterial vasoconstriction, reduced capillary blood flow, and reduced flow of fluid into the interstitium. That's often reversed by a process known as transcapillary refill, so that some extravascular fluid is sucked back into the bloodstream that's replaced by intracellular fluid, so there's whole body fluid depletion. Typically the patient is in a hyperadrenergic state with cold clammy extremities, diaphoresis, often the patient is sweating with dilated pupils but tachycardic, the heart is typically empty with an increased ejection fraction, and there is increased oxygen extraction per unit blood, that's the mixed venous oxygen saturation. The patient typically has lactic acidosis. Now, the lactic acidosis may or may not quantify the degree of oxygen debt, Often there is good oxygen delivery to the tissues, but there is high lactate due to the amount of circulating epinephrine or adrenaline. The most important number to remember is that patients typically lose 30% of their blood volume before hypotension manifests. So if this young man arrives in the ED and his blood pressure is lower than, for example, 100 systolic, that means that he's lost more than 30% of his circulating volume. Multiple lung bone fractures and a fractured pelvis means profound hypovolemic shock. There is a huge amount of bleeding that would have happened in that setting. So this patient needs to be resuscitated. Sheila is 42 years old and she undergoes a laparotomy for hysterectomy. Now this is abandoned because of carcinomatosis. Postoperatively, some hours later, she becomes hypoxemic and then subsequently hypotensive. Her heart rate is 140, the blood pressure is low, 80/36. On the ECG there's a sinus tachycardia and her oxyhemoglobin saturation is 79%. Her hemoglobin is 10.2 and the creatinine is 140. So let's work the problem. Is this genuine? Absolutely it is. Is the heart rate appropriate for the blood pressure? It is. She's tachycardic. Is the patient hypovolemic? Well, there's no reason to really suspect that because she didn't have an operation. They opened her up and closed her immediately. Does the heart contract normally? Well, we need to look into this. Is the heart pumping normally? The function of the heart is to receive blood, that's the diastolic function, and to eject blood, that's the systolic function. So here's our cartoon of the heart. And the diastolic function is the descensibility, and that is determined by the pericardium and the state of the right and left atria and ventricles. Is the heart able to relax and are the valves intact? Systolic function is about preload, afterload, and contractility. In order to eject a stroke volume, you have to have reasonably good diastolic function to receive the blood and good systolic function to eject the blood. So failure to receive is diastolic heart failure and failure to eject is systolic heart failure. Diastolic heart failure is failure to receive, and it's associated with high intraventricular pressures with low to normal intraventricular volumes. There's a high risk of backward failure into the venous circulation, and that often is demonstrated by high central venous pressure. Obstructive cardiogenic shock is failure to receive, and it's seen in several different situations. Massive pulmonary embolism, pericardial tamponade, constrictive pericarditis, and in some situations with ischemia where the patient has a non-ST segment elevation MI, the heart becomes very non-compliant and the patient develops pulmonary edema without having particularly high pulmonary arterial pressures. In this situation, the patient's had a laparotomy for cancer. So that's a high-risk situation. The patient has hypoxemia and hypotension post-op. The patient is hypotensive with a sinus tachycardia and a low blood pressure. So I think this is an acute pulmonary embolism until otherwise proven. The patient should be anticoagulated and the diagnosis confirmed by a CT pulmonary angiogram. Brian is a 63-year-old male with acute shortness of breath. His blood pressure is 90/50 and his heart rate is 110. His PaO2 is 11 kilopascals or about 80 millimeters of mercury on 100% oxygen. His ECG shows left ventricular hypertrophy with T-wave inversion across the anterior lateral leads. His chest X-ray shows cardiac hypertrophy and bilateral infiltrates. His troponin is markedly elevated. So Brian appears to be having an acute coronary event associated with hypotension. Ejection is about preload, afterload, and contractility. And systolic heart failure is loss of contractility, and it's characterized by a low ejection fraction. There is increased filling pressures and volumes required to eject an adequate stroke volume. Reduced ejection fraction is the cornerstone of systolic dysfunction. So this is what congestive heart failure looks like. The end diastolic volume is very large. In the situation, for example, 210 mils. The body will try and eject a stroke volume of about 60 to 65 mils if at all possible. The end systolic volume is 150 mils, so there is a significant reduction in the ejection fraction down to 30% despite a relatively normal-looking stroke volume. Cardiogenic shock is the inability to eject an adequate stroke volume regardless of filling pressure and volume. This results in inadequate tissue blood flow, and we most commonly see cardiogenic shock in the setting of ST segment elevation myocardial infarction. We occasionally see it in patients who are multi-trauma, such as our young motorcyclist who has a severe myocardial contusion. In the ICU, we also see cases of cardiogenic shock in some patients coming back after cardiac surgery, where an intra-aortic balloon pump, for example, may be needed to get the patient off bypass. On echocardiography of this particular patient, he has an ejection fraction of 20% and there is severe systolic heart failure, failure to eject complicated by pulmonary edema. Anne is a 72-year-old female admitted complaining of weakness, sweating and dysuria. Her temperature is 39 degrees Celsius, her pulse is 130, blood pressure 76/44. Her extremities are warm, her lung fields demonstrate reduced air entry bilaterally, there's oliguria. Her hemoglobin is surprisingly high at 16 grams per deciliter with a high white cell count, hypoxemia with a PO2 of 8.2 kilopascals or approximately 60 millimeters of mercury, and her urinary sample is positive for gram-negative bacteria. So working the problem of hypotension here, yes, it's genuine, yes, the heart rate is appropriate for the blood pressure. Is the patient hypovolemic? Well, she may have relative hypovolemia. The heart may or may not contract normally, but it's most likely that she is vasoplegic. And vasoplegic shock is the hallmark of what we see with septic shock. Now, I've already pointed out that we see vasoplegia with iatrogenic stuff like the administration of propofol. We also see vasoplegia with neurogenic shock, anaphylaxis, and if the patient has sustained a sympathectomy, most commonly from spinal or other forms of neuraxial anesthesia. Again, iatrogenic vasoplegia is caused by anesthetic agents, propofol, thiopentone, thiopental, volatile agents, and opioids, direct-acting vasodilators like calcium channel blockers, alpha blockers, labetalol, and then, of course, epidurals, spinal anesthetics, clonidine, and dexmedetomidine. But this is very unlikely in this particular patient. She's got hallmarks of severe sepsis, and vasoplegic shock in the setting of evidence of sepsis is septic shock until otherwise proven. There is widespread vasoplegia and venoplegia. There's an increase in the unstressed blood volume. There's maldistribution of blood flow. There is stasis of blood in the splanchnic circulation that results with other things such as an increase in the circulating catecholamine level, in increased lactate and lactic acidosis, and there may be a reduction in the stroke volume. Steve is 27 years old and he's involved in a motor vehicle accident, pedestrian versus car. He sustains a burst fracture of T2 with complete neurological deficit below this level. 4 hours following admission, his saturation is 85%, his blood pressure is 80/40, and his heart rate is 45. So we're pretty sure that this is genuine hypotension. The heart rate is inappropriate for the blood pressure, although these two things may be tied. He may be hypovolemic from his accident and certainly should be given some volume. It may be that he has abnormality of his cardiac contractility from a myocardial contusion, but the most likely cause of this hypotension is vasoplegic shock due to his spinal cord injury. And we call this these days neurogenic shock. It's multifactorial. In the setting of a spinal cord injury, it's associated with loss of sympathetic tone below that level. And it's also associated with damage to neural tissue that causes release of vasodilator metabolites. Elizabeth is 42 and she's undergoing a mastectomy. She's sat up and a paravertebral block is performed. Anesthesia is induced. She gets neuromuscular blockade. She's intubated. Then she's given coamoxiclav for prophylaxis against surgical site infection. She suddenly turns red and her blood pressure becomes unrecordable. In this situation, there is several things that could possibly be going on. It's definitely genuine hypotension. Her heart rate is appropriate. It's unlikely she's hypovolemic because she's just gone asleep for an elective operation. So there are two things that could be going on here. She could have abnormalities of cardiac contractility, or she could be profoundly vasoplegic. It's very likely that this is iatrogenic. The degree of shock is excessive to be caused by general anesthesia alone. So there are two likely culprits here, both iatrogenic. Local anesthetic systemic toxicity that is last, or anaphylaxis to the antibiotic, and it is impossible to distinguish acutely what's going on. So this patient should be treated for both. She should receive some epinephrine for the vasoplegia and intralipid to sequester the local anesthetic. Let's review this tutorial. Hypotension is caused by loss of heart rate, stroke volume, or peripheral resistance and failure for the others to compensate. Shock is inadequate tissue blood flow or cardiac output to maintain homeostasis. You don't have to be hypotensive to be shocked, and not all hypotensive patients are shocked. In the next few tutorials, I'm going to look at the different causes of shock because I think these are really important topics to understand in critical care. The first one will look at hypovolemic shock and the patient's response to hypovolemia. Now this is something that is relevant for all causes of shock. I'm going to briefly visit monitoring of hypovolemia, and then we're going to talk about resuscitating the patient with hypovolemic shock. I'll see you then, and I guarantee you'll learn something. So that was hypotension and shock. Next time we look at how to treat these particular patients. If you're enjoying the tutorials, please subscribe at YouTube, follow me at ccmtutorials.org, leave me some likes, some comments are always worthwhile, and introduce me to just one of your friends. I'll see you soon.